Ladies and gentlemen, good morning. I'm Dr. Tie from Western China Hospital. It's truly an honor to be here today to discuss a case and emphasize the critical importance of early diagnosis the cause of diarrhea in transplant patients. In the next few minutes, we will explore a case that underlines the challenge and consequence of delayed diagnosis in post-liver transplant patients. I look forward to sharing insight and learning from your expertise as we discuss a case of septic shock due to delayed diagnosis of Cryptosporidium infection after liver transplantation. This case centers around a 55-year-old man patient who was admitted to our hospital on July 15, 2022. His chief complaint was repeat diarrhea that had persisted for 20 days, eventually leading to his admission to the intensive care unit. The patient onset of symptom recurrent diarrhea is 20 days ago. He reported that the onset of this symptom followed an unclean diet. His presentation includes loose yellow stool with mucus, occurring with remarkable frequency 6 to 8 times a day. In an effort to address the persistent symptoms, the patient took barbituric hydrochloride. However, his condition showed no significant improvement. 10 days ago, his condition took a worrying turn. Several concerning symptoms emerged. The frequency of passing dark green stool increased dramatically to more than 10 times a day. The patient also reported new symptoms, including increased thirst, significantly sunken eye sockets, palpitation, and dyspnea. This development warranted further medical intervention, and the patient sought care at the local hospital. In response to those concerning findings, the local hospital decided to discontinue the patient's immunosuppression drug and initiate treatment for diarrhea and suspected internal infections. The treatment includes the administration of milnacipran. 5 days ago, the patient's condition took a severe twist for the worse. He began to exhibit alarming symptoms, including dyspnea and vigilance. After a comprehensive evaluation, the patient was diagnosed with septic shock. The urgency of his condition necessitated the following interventions: mechanical ventilation assistance, continuous renal replacement therapy. As a result, the patient was transferred to the Department of Intensive Care unit. In the patient's past medical history, 2 years ago, due to hypercarcinoma and hepatitis B-related liver cirrhosis, the patient underwent a comprehensive and intricate medical procedures in our history. Following the liver transplantation procedure, he used tacrolimus, mycophenolate, mofetil, and Thelmus to control immune rejection with good result. The patient's admission diagnoses are as follows. The first diagnosis is septic shock. When the patient was admitted to our ICU, we conduct a comprehensive assessment. In terms of the circulatory system, the patient had a temperature of 28.3 degrees Celsius, a heart rate of 130 beats per minute, and a normal blood pressure. In the cardiac Doppler ultrasound indicate that enhanced left ventricular system function. In the peripheral circulation, the patient had a cool extremis and there was no significant elevation in glucose level. In the respiratory system, We also count moisture rate in both lungs, and the oxygenal index was approximately 110 while on mechanical ventilation. In terms of liver and kidney function, the patient's renal function was significantly impaired, with an elevated creatinine level and a marked decrease in glomerular filtration rate. The patient's liver function does not appear to be significantly compromised, but there is evidence of hypercoagulated state. In terms of inflammation and immunity, the patient is experiencing a severe inflammation and high inflammatory state, with a mild degree of immune suppression. At this stage, the patient is experiencing a series of issues, with the most prominent symptom being diarrhea and respiratory stress. It's imperative for us to identify the underlying cause of these problems and address the current circulatory, respiratory, renal, hypercoagulability, and infection issues. Based on the patient's admission condition, we have developed the following treatment plan. After formulating the initial treatment plan, we continue to consider the next step in the patient's management. The patient's ICU admission reason was respiratory failure and subsequent infiltration intubation due to hypertension. We need to identify the underlying cause of this symptom and address him to facilitate weaning the patient off the ventilation and transfer him out of the intensive care unit. I would like to provide an update on the change in the patient's condition during their hospitalization. On day 2, the patient's blood control results indicate a gram-positive coccal infection, and the chest CT scan suggests a fungal infection. In response to this, we took immediate action to strengthen the patient's anti-infection treatment. Specifically, we added Abacus B twice a day and Tigercise every 12 hours. This intervention was aimed to addressing the identified infections. As we progressed to day 5, we began to observe positive change in the patient's condition. The patient's temperature, which had previously peaked, gradually started to reduce. Simultaneously, the oxygenation index began to rise, reaching approximately 300. This improvement was a promising indicator of the patient's recovery. To further facilitate the patient's progress, we reduced the diagnosis of the medication, eventually discontinued the use of the ventilator. Additionally, as the patient's liver count rose, we reduced the microfiltrate mofetil. On day 7, the patient faced a new set of challenges and they developed massive watery diarrhea, experienced unstable blood pressure, and saw a decrease in the oxygenation index down to 200. Additionally, there was elevated inflammatory markers and abnormal liver function. In response to those developments, our medical team promptly took action. First and foremost, we suspended the patient's internal nutrition to elevate the symptom of diarrhea. Furthermore, we introduced anti-diarrhea medication and hepatoprotective drugs. This medication was aimed to elevating diarrhea symptoms and safeguarding the patient's liver function. In addition, we made adjustments to the antibiotic regimen to better address the patient's condition. On day 8, in order to clarify the cause of the patient's persistent diarrhea, we conducted the gastroscopy. The findings during the endoscopy revealed segment mucosal change in the second department and ascending column. which raised suspicion of the specific infection. Despite the patient's multiple stool tests yield negative results. Given this finding and the possibility of anti-type pathogenic infection, we decided to employ an innovative approach. We stain the patient's stool specimen with antacid and subsequently perform high-throughput sequencing on the blood specimen. 2 days later, the consequence result indicates the presence of Cryptosporidium in the patient's blood, and we also find positive result in the acid-fast stained stool specimen. Further examination of the patient-modified anti-stain stool specimen revealed the distinct characteristic. The Cryptosporidium was rose red with a blood green background. In terms of genetic analysis, NGS detects the Cryptosporidium pattern consequence number of 33, covering a total length of 2,851 base pairs on the genome. This finding suggests the presence of a substantial amount of Cryptosporidium in the patient's blood. This discovery is powerful as it allows us to point the precious cause of the patient's symptoms and design a more effective treatment plan to combat the specific infection. Cryptosporidium is a type of single-core bacterium belonging to the Cryptosporidium primary apocalipsis. Is closely related to better-known parasites that cause disease like Morellella. Cryptosporidium was originally identified as an opportunist pathogen in individuals with weakened immune systems, particularly in AIDS patients. However, it can also cause disease in individuals with fully functioning immune systems. Cryptosporidium primarily characterized by the symptoms like diarrhea is a chronic pathogen disease, which means it can affect both animals and humans. Cryptosporidium has notable differences in prevalence between developing countries and development nations. In developing countries, the incidence of Cryptosporidium infection is considerably higher, ranging from 5% to over 10%. In contrast, in developed countries, the incidence is notably lower, typically falling within the range of 1% to 3%. Cryptosporidium is identified as one of the significant causes of diarrhea in young children. Studies have indicated that it may be responsible for as much as 13% to 15% of children who diarrhea cause. Cryptosporidium is primarily transmitted from the fecal-oral route. This means it can be contracted by direct or indirect contact with Cryptosporidium occurs. Such contact can occur through various means, including person-to-person transmission, zoonotic transmission, waterborne transmission, foodborne transmission, and even through the air. Studies have revealed several common risk factors associated with this condition. These include interpersonal contact with infected individuals, particularly infected who are more susceptible. Additionally, contact with pets or other household animals can pose a risk. The symptoms that can occur after Cryptosporidium infection can vary depending on the individual's immune state. In normal individuals, Cryptosporidium infection typically results in a self-limitation disease, but turn our attention to immunocompromised individuals. In this population, Cryptosporidium infection can take a more severe and chronic course. It may be difficult to control, and the symptoms can persist for several months. Those symptoms can include chronic diarrhea, vomiting, upper abdominal cramps, weight loss, and etc. Pathological diagnosis of Cryptosporidium infection rely primarily on the detection of oocytes. If there is a patient of suspicion of Cryptosporidium infection in a patient and the cost-effective and rapid screening method is needed, I prefer the third way. The Keel acid-fast and modified acid-fast combination strain is the preferred choice for initial screening. In the treatment of Cryptosporidium infection, because the Cryptosporidium is the only approved anti-Cryptosporidium infection drug on the market, and the Cryptosporidium works against Cryptosporidium infection through the two key machines, and both of them are rely on the body's immune response. So I recommend that we should control the patient's CD4 T cell and 100 between 100 and 300. After identifying the root cause of the diarrhea, we made adjustment to the patient treatment. On day 10, because Cryptosporidium is not recommended in the instruction for use in an immunodeficiency population, we used an anti-Cryptosporidium regimen of the Cryptosporidium and the allium. 5 days after that, the patient showed a slight improvement in diarrhea, but liver and kidney function continued to be deteriorated. So we administered the CRT treatment again. On day 18, a significant development occurred and the patient's good more transpeptide and alkaline phosphatase level continued to rise. This raised concern about the possibility of Cryptosporidium retrograde biliary infection. Such an infection can lead to complications such as thrombus cholitis, can also pose a risk of immune rejection in patients who have undergone liver transplantation. To address this concern and prevent the potential complication, the medical team decided to make a crucial change to the patient anti-Cryptosporidium infection regimen. The treatment was modified to include Cryptosporidium in combination with allicin. In the following days, the patient's condition became better and better. On day 28, the patient's condition had improved to the extent that they were deemed to stable enough to be transferred to the general ward. In summary, there are 3 key points are crucial takeaways from this case. The first is the consideration of opportunities pathologies. When organ transplant recipients experience prolonged diarrhea, it's essential to consider the possibility of opportunities pathology such as Cryptosporidium as a potential cause. The second is evaluate immune function. In patients take immunosuppression drugs who develop diarrhea, it's vital to assess their immune function. Lower levels of immune cause can lead to increased drug concentrations, potentially resulting in excessive immunosuppression. This evaluation is critical for adjusting medication regimen to achieve a balance between preventing organ rejection and managing potential infections. The last is balancing medication management and immune function. The treatment of Cryptosporidium infection in a region transplant recipient is delicate balance art. It involves careful management, medication regimen, and immune function to achieve the best possible outcomes. Striking the right balance is essential to prevent infection-related complications and support the recovery of these patients. Thanks for your listening.